are given as a observed history taking and given as observed history taking, and observed history taking is then there are two examiners observing you taking a history, and after 10 minutes they remind you to examine the patient if we are not examining the patient. But since we don't have a patient here, so we will do like a traditional case. So I believe that you have seen and taken a history of a patient and examined the patient. So I'll catch that observation taking that from your history, from the whole history that what you're presenting, and the examination part, the technique and things that I believe that I have to catch it from the presentation of your examination findings. Then we will summarize it and then we will discuss it. Now in the current format, there is 20 minutes allocated for history taking and examination of the patient, and another 10 minutes is allocated for discussion. So that's how it goes. So who's going to present?
Good evening, sir. I am Prashant Kodikara, the second batch by the university, sir. Am I audible to you, sir?
I'm happy to see Dr. Gamnia Singh also there.
Hi, Majan.
Very nice to see you, sir.
Yeah, actually very nice. Actually, I am very much thankful to you for just teaching our student. And actually, this was initiated by Dr. Dixon. I must very much grateful to you, both of you, Dr. Ranga and Dixon.
How the present can do that?
Sir, am I audible to you, sir?
Do do me do?
Yes, I am Prashant Kodikara, sir. Prashant
Hari,
Kodikara.
yeah, okay. චූට්ටක් සද්ද වැඩි කරනකොට ඇහෙව මදි.
Okay, sir. I'll speak up. Now, is it audible to you, sir?
Okay, yeah.
May I start presenting the history, sir?
Yeah, please.
Thank you, sir. This is the clinical history of Mr. S. Swarnapala, 71-year-old farmer who is a chronic smoker from Galgaon. This time presented to the hospital due to persistent, progressive, painless difficulty in swallowing for solids more than liquids for last 4 months duration. Patient was apparently well before 4 months ago. Initially, he has noted sense of difficulty in swallowing rice boluses. Later, it progresses as he needed a slip of water after taking 4 to 5 rice boluses, and currently he needs a slip of water after 1 to 2 rice boluses. However, he can manage to drink water without significant difficulty. This dysphagia occurs few seconds after swallowing, and patient localize the sense of difficulty of swallowing in his mid-chest area. And patient denies any pain during swallowing and no nasal regurgitation, no cough, choking at initiation of swallowing, and no difficulty in controlling food in mouth, and no dry mouth and dry throat. And he has, however, he has a weight loss of 5 kilograms during these 4 months, despite preserved appetite, and no history of recent foreign body ingestion, no past history of neurological disorders like stroke or any kind of body weakness. But he has a long-standing history of burning type chest pain and reflux symptoms for 15 years. For that, he has used antacids occasionally when needed, and however, this patient is not further investigated for this long-standing reflux symptoms. And no history of corrosive ingestion, no history of radiation suggestive of radiation strictures, and no complaints of skin thickening, finger color changes when exposed to cold. These symptoms are not complicated with poor exercise tolerance or lethargy. However, patient has a history of one episode of food aspiration 1 month ago, but it has resolved spontaneously, which he didn't seek medical attention, and no history of recurrent chest infections, and no choking attacks at nights or halitosis is not present. Given the relevance, I would like to present his smoking and alcohol history. He is a chronic smoker for 50 years with 20 pack years, and also an occasional drinker who mostly used Arak for last 50 years. Also, he had a strong habit of beetle nut chewing with slate climb for the last 50 years. However, all those habits has been ceased for the last 4 months when he started to develop difficulty swallowing. And no known family history of any kind of carcinomas also. And he could climb 2 flights of stairs without any chest pain or dyspnea, and also he could continue his farming activities with minimum disturbances. With these symptoms, this patient has presented to the surgical unit of Teaching Hospital Kurunegala, and after the clinical assessment, patient was planned for an upper GI endoscopy, and no further investigation and the treatment has been done. In the point I am taking the history. Regarding his past medical history, he is a diagnosed patient with hypertension 1 year ago, and he is on one antihypertensive, probably losartan, and hypertension was detected first at village health camp, and he is following up in Galgamu hospital, and doctor has informed that his blood pressure remains controlled with his good compliance with his medication. No ischemic heart diseases or no respiratory diseases, then the patient is not on an inhalers, and not a known patient with chronic kidney disease. No past surgeries has been done, and he is not on any routine drugs other than what I mentioned, and no food, drug, or plaster allergies. And regarding his dietary history, he is consuming homemade food for long duration, and he denies any frequent usage of outside food and frequent consumption of fatty, spicy foods. Now, but due to this swallowing difficulty, he prefers to eat string hoppers and hoppers than rice, and he is a non-vegetarian person. And regarding his social history, he's a farmer and lives with his wife, who is a housewife, and his wife is healthy and has a good support from her. They have 2 children, but unfortunately, they don't receive their financial or social support from children. Their income is around 30,000 per month, and however, it is manageable for this couple. Nearest hospital is Galgamu Hospital, which they can reach in 10 minutes and can arrange a 3-wheeler in case of emergency. With this disease, patient has some sort of psychological anxiety that might be that this might be a sinister pathology, and he is telling me that he is willing to undergo any procedure to cure it. And on examination, this patient is an average weight patient with BMI of 18.5 kilograms per square meter, and not pale. No white spots can be identified, and not icteric. However, I could appreciate some poor oral hygiene with dental caries, and no angular stomatitis or glossitis, and no oral ulcers, and no any cervical lymphadenopathy, supraclavicular lymphadenopathy, or axillary lymphadenopathy could be appreciated, and neck movements are satisfactory without any pain complaints, and no skin thickening, and no koilonychia, and no nicotine stains, and no bilateral ankle edema, and no palmar or sole hyperkeratosis evidence. On abdominal examination, his abdomen is not distended, no abdomen moves with respiration, and no surgical scars or visible masses. None tender to superficial and deep palpation, no epigastric hypochondrial masses or other masses could be felt, and no hepatosplenomegaly, and no free fluids could be appreciated, and bowel sounds could be heard. And on digital electoral examination, no palpable masses could be felt. On cardiovascular system examination, his blood pressure is 130 by 80 millimeters per mercury, and pulse rate is 80 beats per minute, and I heard dual heart rhythm with no murmurs, and no murmurs, and the respiratory system examination, his respiratory rate is 16 beats per minute, and trachea was in midline with symmetrical chest movements, and resonant on percussion, and bilateral air entry symmetrical, and vesicular breathing present with no added sound. And on the CNS examination, doesn't relieve any focal neurological signs. And on summary, sir, this is a 71-year-old farmer who is a chronic smoker, a beetle chewer for 50 years, and a known patient with well-controlled hypertension. This time presented due to persisting, progressive, painless swallowing for solids more than liquids for 4 months duration. He has long-standing history of reflux symptoms for 15 years and has lost 4 kilograms of weight during this, despite of good appetite, and no evidence of local or distant metastasis or no recurrent respiratory tract infections or evidence of anemia, and the patient is fit enough to do his farming and day-to-day activities. On examination, his BMI is 18.5 kilograms per square meter and he has poor oral hygiene, not dehydrated, no evidence of nutritional deficiencies, with normal blood pressure and pulse rate, and with clear lung fields, and no abdominal masses or free fluids can be appreciated, and no focal neurological signs could be found in the CNS examination. That's my history examination and summary.
Okay, that's a very comprehensive history. How long did you take to take that history?
I took the history in 10 minutes of time in the examination. However, sir, but I had plenty of time to prepare the history, sir.
Yeah, I know. I know that the actual when you're taking the history, did you time it and taken it? Or
yeah, so history part I could history I taking time it's preparations I was ready for a few days and prepared.
Right. Okay. Now when you are in the practical actual patient setup, you would not be able to take a comprehensive history as such unless you have practice, and these questions are come to you spontaneously. One, again, when you are examining the patient, usually you are given about 5 minutes for the examination. So during that 5 minutes, you need to check the weight, height and the weight, calculate the BMI, check the blood pressure, and examine the relevant system, mostly general examination and the abdomen. So in that 5 minutes also, we will expect you to examine, and the examination technique also checked usually by the examiners and the two examiners who are observing you. So that will also be a stressful event when someone is observing you to examine a patient, right? So I'm just telling you the practical situation. It is not easy as such, right? In your summary, can you summarize? Can you give a summary back again?
Okay, sir. 71-year-old farmer who is a chronic smoker, a beetle chewer for 50 years, and a known patient with well-controlled hypertension. This time presented due to persisting, progressive, painless swallowing difficulty for solids more than liquids for 4 months duration. He has a long-standing history of reflux symptoms for 15 years and lost 4 kilograms of weight despite good appetite, and no evidence of local or distant metastasis, and no recurrent respiratory tract infections or signs of anemia. The patient is fit enough to do his farming activities and his day-to-day activities. On examination, his BMI is 18.5 kilograms per square meter, and he has poor oral hygiene and he is not dehydrated. No evidence of nutritional deficiencies. And on system examination, his blood pressure and pulse rate was normal with clear lung fields, and abdominal examination doesn't relieve any abdominal masses or free fluids. No focal neurological signs could be appreciated in the CNS examination.
Actually, neurological things like that නම් ඕනෙත් නෑ. තව පොඩ්ඩක් ලස්සන ගන්න පුළුවන්. 71-year-old farmer presented with progressive dysphagia from solid to liquids, or දැන් liquids එකක් නෑ නේද? solid mainly solid තාම solid දින්න පුළුවන් නේද මෙයාට?
ඔව් සර්. හරි තමයි.
ඒතර progressive කියන්නේ අමාරුයි. Progressive dysphagia from solid to semi solid. දැන් ඉන්දියාප්පනේ කනවා වැඩිපුර
Yes, sir.
Yeah. So from solid to soft diet, progressive dysphagia from solid to soft diet, the last 4 months duration, and without any complications කියලා අර ඔක්කොම කැස්ටරෝට දාන්න පුළුවන්. Without any local complications or systemic effects. Right? තව පොඩ්ඩක් අර කැල්ල කෙටි වෙනවා. Right?
Yes, sir.
So in now in a discussion level, then I will, the another two examiners are there for you to do the discussion part. No? So those examiners have not seen you examine the patient, and they don't know you what they have asked you from your history. They only know the summary that you are presenting. So those are the people who are asking you the questions, right? So like that, now I will ask you the questions. That's a second set of examiners now. In your clinical assessment, what is the cause for his dysphagia?
Yes, sir. Considering his age and his risk factors, especially some elderly age male with a smoking history and with a short duration of dysphagia, which is progressing from solid to hemisolids, and he has a loss of appetite. He has loss of weight in spite of loss of in spite of proper appetite. So my first differential diagnosis be this may be a esophageal carcinoma, sir. And that will be my first differential diagnosis. And other than that, as a second,
Any other possibility?
Other than
Yeah.
that, as a second differential diagnosis, this patient is having a long-standing history of reflux symptoms. So gastroesophageal reflux disease can cause dysphagia, and also as that I take that as my second differential diagnosis. And maybe he may be having a esophageal stricture, and also, sir, although the history doesn't suggest you achalasia cardia, I would consider that as also a differential diagnosis.
So what is the reason for you to say achalasia cardia and the benign acid strictures are unlikely?
Sir,
Why
the
did you
thing
put
is,
it lower down?
yes, sir. So achalasia cardia usually it has a longer time duration, and more specifically in achalasia cardia, dysphagia develops more first the predominantly dysphagia is the liquids, and also this achalasia cardia it could have some recurrent chest infections and evidence of halitosis like those things. So that's why I take achalasia cardia down the list.
Strictures?
Strictures is possible in this scenario, sir, even because it could be it could be possible, sir.
Any reason to put it downward in the lower down?
So in the strictures also it should have some sort of long duration, sir. This is a 4 months duration, and no evidence of radiation strictures, and yeah, that's why. Sir. Whatever, however, I'll consider it as my third differential. I will consider as my third differential diagnosis.
Stricture is your third differential diagnosis.
I mean,
This
sir,
one is carcinoma, agreed. Second one?
then that gastroesophageal reflux disease. Those
Reflux
two are
disease.
my
All right,
main.
okay. So
Those are
reflux disease, what is the pathological behind the reflux disease causing dysphagia?
so the so with the gastroesophageal reflux disease can cause strictures. Can progress into dysphagia. It can be when we consider strictures, the gastroesophageal reflux disease can cause strictures. Otherwise, the gastroesophageal reflux disease, when there is long-standing gastroesophageal disease, it can cause the Barrett esophagus, then progress into the adenocarcinoma. Adenocarcinoma sequence.
The Barrett esophagus. Barrett esophagus can cause dysphagia.
Yeah.
Right. What are the benign causes of dysphagia?
The benign causes of dysphagia, as I mentioned, it could be it is an acute setting, it could be a foreign body. Then otherwise there will be strictures, esophageal webs, and then like neurological causes and systemic sclerosis. Those comes into my list.
Okay. Now, if this patient presents to you in the clinic, how would you start investigating him?
So first of all, I would like to review now. First of all, I will review any previous records. I will review it, sir. Then,
no records. First time presenting to the clinic.
Yes, sir. Then after the clinical examination, now I have to come some differential diagnosis. So I have to narrow down those differential diagnoses. For that, I would have to investigate this patient, sir. So regarding investigations, I have diagnostic investigation and staging investigations and the fitness assessment investigations, sir. For this type of dysphagia is an alarming symptom, especially in this age. So I will my diagnosis.
Point. Now you have limited time. No?
Yes, sir.
Right, within that 10 minutes, you need to show your knowledge.
Yes, sir. My diagnostic, yeah. My diagnostic investigation would be upper GI endoscopy plus biopsy and biopsy. And as it could directly visualize the lesion, and I can see the morphology and can take biopsies from the active edge. And then my staging investigations would be CECT, neck, chest, abdomen, and pelvis, provided that this patient is having good renal function and no contrast allergies. And for the surgical fitness, I would like to do a full blood count and see the hemoglobin levels and the platelet levels, and also the fasting blood sugar and the grouping and DT has to be needed. And for the lung functions has to be assessed and chest X-ray has to be taken, especially as this if we are going to find surgery, it's a single lung ventilated surgery, so the lung function has to be thoroughly assessed. And the serum albumin level is also been has to be assessed due to the nutritional status, and we need good healing of anastomosis. And also for the cardiac functions, I will take the ECG, and with the senior opinion to the echocardiogram has to be done. And then for the renal functions, I would like to do the serum creatinine and serum electrolytes, including calcium and the magnesium. Especially, when the patient has to undergo CECT for the surgeries, and the other complete liver profile has to be done, sir. Those are my baseline. Those are my investigation plan for this patient.
Right. Now, if the patient is having a squamous cell carcinoma 27 centimeters, perhaps a short squamous cell carcinoma 27 centimeters, tumor has only invaded up to the muscularis propria, that's gone beyond the submucosa and gone into the muscularis propria. And there are few lymph nodes on this vagus, on your various vagal nodes on the CT scan, and there are no other metastatic disease. So, what would you offer this patient? 27 centimeters.
What would be? So it is a locally advanced disease situation. So the management has to be decided by a multidisciplinary team approach. Usually, for the locally advanced diseases, we can generally we can go with the surgeons.
What are the options?
So with the input of the multidisciplinary team, there are 3 types of surgeries, but before this tumor is on the mid-esophagus, and as it is a small as it is more squamous cell carcinoma.
25 or 27 centimeters means at what level?
Sorry, sir. It's a low in the lower esophagus. It's a low. Sorry? It's in the lower esophagus.
Lower esophagus.
Then, sir, so as it is squamous cell carcinoma, there is a place of neoadjuvant chemotherapy given prior to surgery. So, with the multidisciplinary approach, I would like to take it and then underwent surgery. I have 3 surgical options for this patient. Those are the Ivor Lewis and Orion and the Macion surgeries. Yeah, that depends on my senior opinion. And,
Okay. Any other options?
sir, if we are going to a surgery, those are the options. Sir. But before the surgery, we have to get the consent from the patient. What are the patient wishes? Whether he's happy to go with the surgery. So in that case, we can try some other options other than surgery. Yes, we can go with the we can go with the chemo radiotherapy and like that. Those are the 3 surgeries that I know.
Right. Okay. Now, if you are the house officer, now how would you prepare this patient for a esophagectomy?
Yes, sir.
Now, yes.
So as a house officer, now if I have to prepare this patient for esophageectomy, first thing I should have to do is this. I have to make this. I have to optimize this patient, sir. So for that, as I mentioned, I have already mentioned that I have doing my surgical fitness assessment investigation. After that, and proper nutritional assessment has been done. This patient's BMI is 18.5 kilograms per square meters, and it's in the lower margin of the normal range, sir. However, I would like to target with the nutritionist opinion. I would like to target of 25 to 30 kilocalorie per kilogram per day, and also protein 1.5 to 1.5 gram to 2 grams per day target, and go with it. And for the assessment of the nutrition, I would wait for I will measure the BMI after 1 week and serum albumin after 21 days. Clinically, this patient doesn't have any anemic features, but hemoglobin levels has to be assessed. For the according to WHO recommendations, now it's for the major surgeries, it's about 13 milligrams per deciliter is the target range. And also I have to optimize the lung functions. Also, and I have to and then I have to arrange. I have to call my our anesthesia team and contact about the epidural anesthesia, and I have to book an ICU bed, sir. And on top of this, all the things before that, I would have to talk with the patient and break the bad news and explain about the future management. Hello. Sir, am I audible?
Yeah. Now, there's someone raising the hand for a long time. Jayaveer. Anything you want to comment? නැද්ද ජයවීරට මුත් කියන්න දෙයක් නැද්ද? Right. Now we will discuss we will discuss critically what are the things that we have done correctly and what are things we have done wrong. Nothing basically wrong was done. But Gamini, would you like to give some comments to him? What's your name? Chamath, sorry, Damidu.
Yes, sir.
Yeah.
Hello.
Yes, sir.
Yes, Ranga, I think you did a wonderful job, and his history is quite okay, but I think it's too long, and because I don't think he can complete this sort of history within short period we have given to them.
Yes.
And as Dr. Ranga commented, and that's very important because we can't prepare, prematurely, because we have to target for the exam setup. Exam is a very stressful condition, and in that condition, and we should be able to complete the things in a proper way. And Dumidi's history is quite okay. And one
Thank
more
you, sir.
point I like to point out, you said that persistent, progressive. If it is a persisting, it's the one thing, and the progressive is one thing. If it's a persisting, I think it's remaining in the same condition. But if it's a progressive, that means it's advancing. That's one of the point I just noticed.
Thank you, sir.
Yeah.
Yeah, another one comment. Now, when you are presenting, it is very nice and it is very comprehensive when you are telling this. So I would do investigations. The investigations are categorized divided into these things. That's very nice. The previous setup. Now at this current examination setup, we only have 10 minutes to assess your knowledge. So in that case, I would rather minimize your icing around the cake. You just give the facts straightforward. So I would like to investigate this patient immediately with upper GI endoscopy, followed by CT scan. And by the time I'm waiting for the histology, I will do the other investigation to see whether the patient is fit for surgery. Things like that, right? Rather than giving a topic, say, I will investigate this patient on 3 areas: diagnostic, to see the fitness of surgery, and to see the spectroplasty. It's wasting of words and time, right? ඒක
Yes.
පොඩ්ඩක් පුරුදු වෙන්න, that would be better. And වැඩි නාස්ති කරන්න එපා කාලේ අර you know, to describe things more, right?
Thank you, sir.
And yeah, basically you're all right. You will pass the exam if you present it like that, definitely.
Thank you, sir.
And what else are there? There are some questions I will come. Anonymous has wrote reflux caused by Barrett's because yeah, okay. And Macion, I will use a Noringa, which one is type of thing. Macion is best. How to consider such type of consider? Okay, now this is with complex. Now, esophageal. Shall I? No, I can share my screen if possible. I have a okay. You know, I have my lecture on dysphagia. So if I can get that, I'll just go through the thing, just the slide that I have. Uh, uh,
Ranga, can I just comment one more thing?
yes, sir.
And the thing is, because he said that he had a differential diagnosis.
Yes,
As you correctly pointed out, that rather than just saying that I will investigate in point of diagnosis and staging and so on, first of all, we have to diagnose first. We don't know whether it's a malignancy or not.
yes,
So then we have to say that I'll just, first of all, I'll do the upper GI endoscopy to confirm my diagnosis. And depending on findings, I'll proceed.
mm,
I think that should be the way I suppose. Because as he said, if it's a gastroesophageal junction with ulcers and having a spasm while they're eating, and so he can
yes,
get dysphagia. So in that case, you don't have to stage the disease.
exactly.
Right, right.
මම මේ පොඩක් දාන්නම් මගේ මේ ස්ලයිඩ් ටික. Yeah, මට මේ පොඩි ටික තුනක් විතරයි පෙන්නන්න ඕනේ. So investigation keep ටිකව තමයි තියෙන්නේ. To arrive at a diagnosis, various solo video fluoroscopy ඔය ටික ඔක්කොම තියෙනවා අපේ මේකත් එක්ක. Just pictures and various solo pictures. Usual other investigations, right? And yeah, so it's very considered extra major complex surgery. When we try to depend on now, depending on the course and stage, right? Achalasia cardia, digital management, carcinoma. Carcinoma is basically dora, adenocarcinoma, and squamous cell carcinoma, and the site, the proximal esophagus, the mid esophagus, and the lower esophagus. The carcinoma around 25 centimeters is the mid esophagus. Lower esophagus is usually after 30-35. So up to about 20 to 25 to 35 we considered, sorry, up to the 30 we considered mid esophagus because the carina is at 25 level. So around carina, above the carina is considered upper esophagus. Below the carina and lower down is called mid esophagus. And the gastroesophageal junction is about 35 to 37, 40, that region. So we are measuring from the endoscope oral incisor. From that level we measure 25 centimeters is the carina. Below that, up to 27 centimeters, we consider mid esophagus. Beyond 30 is the lower esophagus. Right? So depending on the site, upper esophagus, generally radiotherapy is the treatment of choice. Surgery is not done because it is very mutilating surgery. And you know, when you want to remove the esophagus, you need at least 10 centimeters proximally and distally. So upper 1/3 tumors means give me a second. Hello. Hello. Right. Okay, sorry. Upper 1/3 tumors means from pharynx to the carina. So upper 1/3 tumors are less than 25 centimeters. We consider from incisor tooth to the junction of the cricothyroid junction is about 20 centimeters. So after that, 20, 22, 23 centimeters tumors are considered upper esophageal tumors. And when you are considering, you need to take 10 centimeters from that level, that means you need to take the pharynx out. You need to remove the pharynx, larynx, and upper trachea also if you are removing a esophageal tumor in the upper esophagus. So upper esophageal tumor surgery is out because it's too brutal and mutilating, and yes, you know, patient will not remain anything. Right? That's called laryngopharyngoesophageal. Not done. Basically, not done in many countries. Mid esophagus and lower esophagus, depending on the histological type, squamous cell carcinoma or adenocarcinoma, we decide surgery and chemoradiation. Squamous cell carcinoma, mid esophagus, organ confined disease. That means tumors less than T2N1. Right? Tumors less than T2N1. That means tumors not invaded beyond the muscular aristocracy. That means not gone beyond the adventitia of this esophagus. We consider them as early tumors. So early tumors, there are two options for squamous cell carcinoma. Either patient can be given radical radiotherapy or chemoradiation, radical chemoradiation, or radical surgery. Those are the two options: radical chemoradiation or radical surgery. Radical chemoradiation, they give a high dose of radiation in combined with chemotherapy, and radical surgery, either it has to be a Ivor-Lewis operation or Akiyama's 3-stage lymph node dissection. Macules and Oringas are not considered curative surgeries, right? Because we are not going to remove any, we're not going to remove any lymph nodes, right? So either radical radiotherapy or radical surgery, right? Lower esophageal tumors, there can be either adenocarcinoma or a squamous cell carcinoma again. Still, the squamous cell carcinomas are more than the adenocarcinoma, but adenocarcinoma rates are coming higher up. Even when we were in stars, it was coming higher up, but still, I think in Sri Lanka, our statistics shows squamous cell carcinomas are more than adenocarcinomas. It depends on squamous cell carcinoma. Again, you have the option of radical chemoradiation and adenocarcinoma. You can give neoadjuvant chemotherapy followed by surgery. So radical chemoradiation, again, same way, radical chemoradiation only for squamous cell carcinoma. And squamous cell carcinoma can be given neoadjuvant chemoradiation and surgery. And adenocarcinoma can be given neoadjuvant chemotherapy and surgery. Or you can go for primary surgery depending on the stage of the patient. That means if the tumor is early, that means less than T2 and 1, right? Stage 2 disease. If it's going beyond stage 2 disease, then you have to be really discussing the multidisciplinary team and come to a conclusion what are we going to do. Then they can say, okay, we will give the radical radiation, we will give high dose of chemotherapy, and we shrunk the tumor, and then after restaging, then we'll discuss what are we going to do for the next one. Like that, it's all depending on what they are doing with your case, right? Clear?
Yes, sir.
Oringas operation, the classical Oringas operation, what they say is transhiatal esophageectomy, and you are supposed to do at least a paraesophageal lymph node dissection through the transhiatal thing, but generally no one is doing it. Practically, it is very difficult to see the thoracic cavity through the abdomen, through the diaphragmatic hole, right? So generally no one is doing it, and because of that, Oringas is not considered a curative surgery. Oringa is one of the best palliative operations we can do for esophageal carcinoma. One of the best palliations. The optimal palliation is can be come through Oringas. Any questions? And Akiyamas is what you call pre-field lymph node dissection. So our Akiyamas is not, Akiyama is different from Mekios. Akiyama is operation where the abdomen is open, the chest is open, and the neck is open, and all three levels the lymph nodes are dissected. In Mekios operation, there is no lymph node dissection has been described, especially in the neck. They describe lymph node dissection in the chest and the abdomen, but not in the neck. Akiyama is the only person who has described lymph node dissection in the neck, abdomen, and chest. So that is one curative operation, and Ivor Lewis is other curative operation. Other things are not curative. Okay. Welcome. Any questions on this? What we discuss? Yeah. So how to consider surgery type according to site of the lesion? I think I have asked that question. So your upper esophagus is basically no surgery because surgery is too bad. Lower mid and the lower esophagus surgery depending on the stage and the histological subtype. Does the patient need a feeding tube? Well, it depends on the patient. If the patient is well nourished before the operation, there's no need to feed it before the operation. But definitely after the operation, patient need to be fed So for that, we usually put a feeding jejunostomy tube during the operation. Should we give nadectina? Sorry about that. I'm on call for the wall. Uh, yeah. Sorry, where was that? Sir, should we give esophageal carcinoma as it, or should we give esophageal CA as a DD, or divided to squamous cell carcinoma and adenocarcinoma? No, squamous cell carcinoma as a DD is enough. You can't give a DD as a squamous cell carcinoma or adenocarcinoma. Carcinoma is carcinoma. The squamous cell carcinoma and adenocarcinoma is histological diagnosis. No, so you can't clinically say it's a histologically what we are dealing with, right? So don't try to tell squamous cell carcinoma or adenocarcinoma on your DD. That might, the examiner might think that you have seen the histology report of the patient, right? So by clinical diagnosis is squamous cell carcinoma of the esophagus means like you know the case. So don't go into detail diagnosis like that. Is achalasia cardia causing dysphagia for liquid, or is it both solid and liquid? Achalasia cardia start with liquids and then gradually go into solids. So with the lymph node being positive, can we still do surgery or palliative care? Well, still we can do surgery. That's why I gave you a scenario where surgery is possible. Tumor has invaded only up to muscularis and a lymph node is there. That means there's only periesophageal lymph node. So curative surgery can be done. Right? T2 and 1. So our finals are coming soon. So please be kind enough to give us a guidance how you should spend our study leave with being balancing our MCQ and SCQ and clinical stuff. Well, it's it's well, if your exam is close, I would say that don't consider it as study leave. You do see as much patients as possible, and that the subjects are also there, not only surgery and also medicine, and everything. So go and see more patients as possible, and study the case with your books and your internet, and you have your tabs with you. So study the case with the patient. That would be the best thing for you to do, and take histories as much as possible, and take good history taking and examination should be in your reflex level. When you are tying your shoelaces or when you are driving a car or anything, in the beginning, you have to decide which gear to put and which way brake, with which pedal to push when you are changing the gear and things like that. So when you're starting to drive, but after some time, these things become automatically done. So your history and examination also should be at that level, and it should be done automatically. And your brain should be able to analyze those gatherings also automatically. Then only you can give a good case and good discussion at the end. Right? See more patient as much as possible. That's my advice. So if you find malignancy at 27 centimeters, do we have to do bronchoscopy to assess the bronchial invasion, or EUS is enough? Well, EUS is also a luxury, but if your CT scan is not showing any invasion to the bronchus, no need. Or patient is clinically having no features of bronchial invasion like chronic persistent cough or hemoptysis, there's no indication to do a bronchoscopy unless you have clinical features or imaging features to show this invading the bronchus. Endoscopic ultrasound is also luxury. If you have, that's wonderful. Is there a place for curative chemo in uppermost tumors? Not curative chemo, just curative chemo radiation. Right? Curative chemo radiation. So when can the patient eat after surgery while waiting for recovery, or do they get parental or tube feed? Well, initial few days, initially after surgery is a major surgery, major undertaking. So initial few days, first 48 hours, patient can be given parenteral nutrition. So there's a central line being inserted. Actually, one question we used to ask in the patient, in our exam is how many tubes are going to be there in the patient following hysterectomy. The number is actually 10 tubes will be there, right? There will be a G tube, there is a central line, there's a epidural line, and there are IV cannula, and there is a bilateral IC tubes, and there is a abdominal drain, and there is a feeding edge. So altogether, and a urinary catheter. Altogether, there are 10 tubes, right? So one of them is a feeding edgenostomy. So we always start with the central line the first 48 hours. Then we start when the bowel sound starting to hear, when we start the feeding edgenostomy feeds. And feeding edgenostomy can be kept for some time. At the ideal time is at 10 days, we do a barium or gastrography follow and see the integrity of our anastomosis. If the anastomosis is functioning, if there are no anastomotic leaks, then we can start with a soft diet for to eat. 10 days is the time. Can you give a summary of the treatment options? I think I gave that. So follow-up plan after surgery. And the follow-up plan, usually patient will be there in your ward for about 2 weeks, or a little more than 2 weeks, probably 3 weeks, and discharge the patient, get them down in about another 2 weeks or 3 weeks time while the history will be available. And after that, patient can be followed up with every 3 monthly for the first 2 years, and then 6 monthly for the next 2 years, and annually. The following the operation, depending on the surgery what they have done, that's very complex follow-up because the patient will follow up surgically as well as oncologically. If the patient was underwent neoadjuvant chemoradiation and then followed surgery, patient will be followed up surgically and oncologically, no other treatment. But if the patient has not undergone any chemotherapy or radiotherapy, patient may be need radiotherapy or chemotherapy depending on the surgical finding. If the nodes are positive, they usually give them chemotherapy. And radiotherapy for the esophageal bed. So, those things are being followed up by oncology team at their clinic. When you refer the patient to oncology clinic, right? So you don't need to know the detailed follow-up there. General follow-up is 3 monthly. for the first 2 years. Then you can do endoscopical follow-up every 6 monthly in this patient to see any recurrences. And annually do a CT scan on them. With the distal resection margin with 10 centimeters as well as the yes, distal resection margin should be 10 centimeters in the esophagus. If it is coming to the stomach, distal margin should be 5 centimeters. So why do they put coffee into the feeding tube? Coffee into it? I don't know. Who put the coffee into the feeding tube? You mean are you can you question put some elaboration? I don't know why you are what you're asking. Please structure the question and answer. So when can we be sure the patient can be start feeding after surgery? One thing I answered that. Can you please explain how to optimize the patient in nutrition before and after surgery? Before surgery, patient if the patient is very poor in nutritional down, then you can either do central line or a feeding ileostomy. So best thing is enteral feeding, start a feeding ileostomy and feed the patient for about 4 weeks maximum, not more than that. If you're going to make the patient, optimal, beyond 4 weeks, the tumor will grow more and more. So you have to restage everything again. So you refeed the patient for maximum for 4 weeks and then reassess the albumin level. And if the albumin level has come to the normal range, that would be enough. Right. Then you can go ahead with your surgery. Post-operative patient can be given either parenteral nutrition or feeding adjustment feeding after the operation. That's why I described earlier. How long the patient is kept feeding on feeding tube? Yeah, we discussed that, right? After 10 days, you can consider reversing. If there's any leak in your anastomotic site, then you can keep another 1 week more. Like that, then again you do your study and see whether there's a leak or not. When taking consent, what are the specific things need to be covered in such surgery? Well, consenting is another huge topic. When you are taking consent, you need to tell one is the diagnosis of the patient, of the condition the patient is having, and other thing is the, the proposed treatment option to the patient. This is what we are going to do. Thirdly, the complications of that operation, like it will be done under general anesthesia, and there will be tubes going on, and you should be kept in feeding tubes for the next few days of for you to be fed. Those things should be mentioned. If there's going to be any other special consideration, you should mention. And if the patient is giving given any blood transfusion, those things needs to be mentioned. So those are also part of the present procedure. Then you have to mention what are the other possible options patient can have, like neoadjuvant chemoradiation, and those things are also there as possibilities, and describe the advantages and disadvantages of proposed procedure and the other procedures. Then thirdly, then you need to tell that if the patient has not done any kind of treatment, what would be happen to the patient? That's like the natural history of the disease. What can be the end of the disease? How the patient is going to die from this disease? You need to explain. In this sort of question, what are the three ideal DDs? Is the goal you are? Yeah, there are no ideal things, but he has got the yeah. the Midu explained was acceptable, right? Prior to the surgery, how to know whether which patient need nutritional optimization? Can you please discuss the pre-op preparation of patient undergoing a surgery? Now, which patient needs pre-op nutritional optimization depending on your nutritional assessment. So you need to assess the patient because patient has not been eating properly for the last 3-4 months. You need to assess the patient's nutritional status by, mainly by the BMI and then by the serum albumin levels. If the serum albumin levels are less than optimal, that is an indication patient is not having adequate reserves of amino acid in the body for recovery. Then you need the patient to be fed prior to the operation, or at least the serum albumin comes to normal level. You have to feed the patient the albumin to be normal, not rather than giving albumin itself. It should be given albumin as food, and it should be produced from the body because that is an indication that the body has come to a status that body is now producing the adequate amount of proteins inside the body. That means the amino acid pool has come to the normal level. So the healing can occur without any interruption. Right? If you are given albumin artificially, that is an artificially created situation where the albumin is becoming normal. But that is not the body producing your adequate amount of proteins. Pre-operative preparation, I think we discussed that. I think Namidu also described many things about pre-operative preparation. That's what we ask from you. As a house of the level, what are you going to do? While we are resecting the tumor, is it to have 10 centimeter section distally? Why it can be 5 centimeters? Why it can't be 5 centimeters? 5 centimeters can be done distally, yes. If it is stomach, we can have 5 centimeters distally. Because when you are doing a surgery, we always take the gastroesophageal junction. So when you are taking gastroesophageal junction, 5 centimeters from the gastroesophageal junction is a standard distance we take. When it comes to palliative care, what is the best? Well, it all depends, right? Palliative, the best palliation is palliative is restricted, like oringas, right? If the patient is fit enough to undergo oringas operation, doing the oringas would be a best palliation because that will give the maximum benefit of the patient will not be dysphagic. After that, esophageal stenting would be the best palliation if the patient can afford a stent. And feeding generosity is not considered palliation, but ultimately what we do is that. Wilson disease can't be taken as a DD. Can be taken, but very lower down in this patient. So is achalasia cardia a pre-malignant condition? Yes, achalasia cardia is considered pre-malignant lesion. And another question, sir, why we are doing upper GI minimum, how many samples would you take? There's no minimum sample. There should be a sample taken from the lesion, usually from the edge, and that's one sample. And you can take one sample from the base of the lesion and make another sample if you can from the normal as well as to compare and mark them separately. The best sample would be from the edge of the lesion on the it will be usually ulcerative kind of a lesion, so you can see the inverted or inverted edges of the lesion. You can take a sample from that. Right? At least 2 or 3 would be all right. Do we need to know the type of surgeries in detail? No need to know the types of surgeries in the detail, but if you know at least there are 3 operations done, the transhiatal operation and the Ivy Lewis are the standard 2 main operations done in Western world. That is enough. The Akiyama is done in Japan and the other countries, and even in Sri Lanka, the people who are trained to do Akiyamas. And if you know the detail, better. Well, it's like this: when you are sitting for an exam, there's no limit in that exam, right? So those who say I will do surgery for esophagus will get some kind of mark, and those who will say I will do evaluation operation for this surgery will also get another mark. So you can decide whether you are going to get a lower mark or the higher mark, right? There are things that you must know, what is called the co-curriculum. You need to know that, otherwise you will not pass you. Secondly, there are things that you better know, and you should get a better mark. You get a higher mark if you know those things. And there are things that you must know and you should know, and there are things that nice to know, right? Better to know and nice to know things. Nice to know things. If you know that, you if you are know your core things and if you know your better things, and then only we go for the nicer things. Like what is the dose of radiotherapy that we give, kind of a thing, and what are the chemotherapeutic agents that we are using in neoadjuvant chemoradiation is being carcinoma. If you have done well in your examination, in your presentation and exam, if you have time, then we ask those things, right? There are instances that I have asked those things in medical students and got to know the correct answers also, right? They got very high marks, 90, 95 marks were given, right? So it's like that. So knowing is better rather than not knowing. So what is the TNM cutoff? We need to take considered mucosal ablation, and after what stage is esophageal also not suitable. Clinically, there are such cutoffs on the for the subjective. Well, TNM is only for the mucosal ablation. The mucosal excision is only for T1A, that is tumors which have not breached the submucosa. As soon as the tumor breaches submucosa, we believe the lymphatic submucosal lymphatic system will carry the tumor into the periesophageal lymph nodes. So anything beyond uh, above the muscularis propria is considered can be taken locally as T1A, right? And again, T2N1 is considered T2N1 is considered early esophageal carcinoma. Anything beyond T3 means tumor is invading the beyond the muscle layer, going into the adventitia. T4 means invading the other structures like the aorta or the carina or something like that. So those things are not considered suitable for surgery immediately. And what else? And a nodal status. If there are nodes very distant, say upper esophageal tumor having nodes in the distal celiac axis, or a lower esophageal junctional tumor having nodes there in the supraclavicular fossa, is considered beyond surgical resection. And entry and metastasis in the liver or lungs or any other metastasis. Stage 4 disease. Is there any rule the maximum size of resectable tube? No, there's nothing called size. Size එකත් එක්ක කිසිම සම්බන්ධයක් නැහැ. It's only the invasion depth. The patient history of lethal chewing and smoking, if they have complained loss of appetite, can we also consider lower esophageal carcinoma, or does it have the gastroesophageal junction? So we can only consider lower esophageal carcinoma, loss of appetite, is just one indication of adenocarcinoma. Adenocarcinoma may very rarely arise from the mid asparagus. I have seen a patient who has got adenocarcinoma in the upper asparagus. They can rarely have adenocarcinomas in other areas also. We can't say whether it's adeno or not from the history itself. Right? So don't commit yourself for the histological subtype. If there's loss of appetite from the beginning, it is just a suggestion that may be an adenocarcinoma. What are the things we have to assess during follow-up? I think we discussed that. So how many participants today? I don't know. There are about 200, almost 300 were there. If the carcinoma invades the vocal cords, how would you manage the patient? Well, if the carcinoma invades the vocal cord, that means it's upper esophageal treatment. So basically radiotherapy. Secondly, the carcinoma esophagus in the mid-esophageal region can invade the recurrent laryngeal nerve at the mid-esophagus, especially the left part. That will have the vocal cord palsy of the left vocal cord because the left recurrent laryngeal nerve fits around the uh, curves around the arch of aorta and the ligamentum arteriosus segment, come onto the lateral wall of the esophagus and rise on the tracheoesophageal groove on the left side. So, esophageal carcinoma on that region can invade the left recurrent nerve. That is an indication of local invasion, local advanced tumor. Right? So, if it is going to vocal cords, esophageal carcinoma going up, that means local invasion T4 lesion in the upper esophagus. Radiotherapy, chemoradiation is the only treatment. If at all, if it's not responded to chemoradiation, then surgical excision, putting a patient in feeding genostomy and tracheostomy. Permanent tracheostomy and feeding genostomy. So if the patient has advanced carcinoma with liver mets, for palliative feeding, do we stenting or PEG or gastrostomy, which is with chemoradiation? Well, ideally, it should be a stenting and patient can be given chemoradiation to the esophagus and chemotherapy for the stomach lesions. Gastrografin can be used for checked anastomotic leak. Yes, and the gastrography no barrier can be used. When we are asked what is the best surgical option, what would be the answer? It depends on the site of the tube. So, if the tumor is mid or lower esophagus, squamous cell carcinoma, the best option is the three-field lymph node dissection, the Akiyama's procedure, where they remove the lymph nodes in thoracic cavity, abdominal cavity, and the neck. Because that has shown equal as neoadjuvant, complete therapeutic chemoradiation. But the problem is when you are giving chemoradiation, there is a chance that it can come back again because esophagus is still intact. So when you are removing the esophagus, patient will not be having that uh, chance of recurrence. So little higher, numerically little higher chance is there when you are when you have been done Akiyama's procedure. That is the only surgical procedure which has shown more than 60% of 5-year survival in esophageal carcinoma. All the other procedures, the 5-year rates are less than 20%. So, how to answer the question? How do you assess the nutritional state of the patient before surgery? Yeah, So how do you assess the patient before the surgery? There are clinical, anthropometric measurements, and biochemical measurements can be done to assess the patient nutritional status. Right? So anthropometric measurements are the clinical measurements are ask the patient what they can eat, what are they usually eating, what is their from the history, and anthropometric measurements are your height, weight, and the BMI. Basically, other than that, you can do a skin fold thickness, mid-arm circumference, and all these things and assessing of the muscle mass, and the muscle strength and subcutaneous fat layer. And then you can do a biochemical test, see, and your blood count, hematological and biochemical test, blood counts, and all these things. And then you can do basically your serum albumin level and serum protein levels, and the amount of albumin and your serum protein, and the albumin globulin ratio. And all these things are there in Billion Love Nutrition Assessment, big chapter in the principles of surgery in Billion Love. Please go and read that. You will get a good idea how to assess patient nutrition. Is it laser treatment or stenting better for palliative options? I don't know whether there have been any trials done which is better than the other one. Laser treatment also can be done, but I don't know. We don't have any lasers with us, so we have no idea personally. And I don't know about any trials comparing those two. I'm very sorry about that. So ඕන්න පොඩ්ඩක් ඉන්ටර්නෙට් එක සර්ච් එකක් දාලා බලන්න කොයි විදිහට හොඳ කියලා. එච්චර දේවල් ඔයගොල්ලන්ගෙන් අහන්න බය වෙන්න එපා. Before the surgery, do we want to make a feeding diagnostic as a patient nearby about 10 days after surgery? Not before the surgery, during the surgery, because we are opening the abdomen, we will do a feeding diagnostic at the time of surgery. So post-operative patient is fed through the feeding diagnostic. Okay? During the surgery, we will do that. So what is the most appropriate investigation for diagnosis of achalasia, endoscopy, barium solo, or manometry? Well, endoscopy may not be showing anything at all in the early achalasia cardia, and barium solo will show you the classical picture, but the diagnostic investigation is esophageal manometry that will show you the exact pressure of the esophageal junction compared to the rest of the esophagus. So you can say if it is more than the range of normal esophageal sphincter tone, that you can diagnose this is exact achalasia cardia, right? The ideal investigation is esophageal manometry, right? Clear? Same way, gastroesophageal reflux disease, the ideal investigation is esophageal pH monitoring. So that is never done in this country. What we do is we do endoscopy and observe the features of esophageal reflux disease. And if you want to diagnose properly the diagnostic technique of doing gastroesophageal reflux disease, then you have to put a pH monitor, keep it 4 centimeters above the gastroesophageal junction, and see it's called test of 4, right? And see the pH is less than 4, more than 4 hours is considered as gastroesophageal reflux disease. So like that, ideal test is something else, but clinical evidence is there, right? So barium solo is the most practical test in our setup because we don't have esophageal manometry everywhere. So what is the palliative options when there's not? So what are the palliative options and when does go to palliation? Well, palliative options are basically esophageal stenting, and we consider palliative options when the patients are not suitable for any curative treatment options like radiotherapy or surgery. So radiotherapy can be given to any elderly or any other conditions the patients are suffering, but chemo may not be able to be given. If the patient can be given chemo and radiotherapy, both patient is usually fit enough to undergo surgery also. So those who are not fit enough to undergo chemotherapy are given radiotherapy and stenting. And those who are having disseminated disease like lung mets and liver mets and things, anyway they will undergo palliative treatment for alleviate dysphagia, but other palliative treatment is for minimize the effects of secondaries. There's no radical surgery for them. Is it barium solo or water soluble contrast used as an anesthetic on the post-operative day 10? Well, it's like this. Barium is the ideal. But if you are having any suspicion of leak is there, then you can give gastrographic study. Right? The fear of that is that if there's barium was given, if there's any problem, if the barium get aspirated, they are going to have problems with the lung. That's why this water soluble thing, the gastrography was discussed. But ideal is the barium. If you have barium, if the patient is, if you think that patient is suitable to swallow, then you can give a barium. Because you need to realize now, even though the patient was on a on a NG tube and feeding device with nothing being fed, patient is following saliva, right? Patient is following saliva. Usually, a human being swallow about 3 liters of saliva per day. If there's any leak, the saliva would leak out, right? So by 10 days, you will rather know whether there's a leak or not before you do your gastrography barium study, right? But we need to confirm that with imaging. That's why we do a barium solo. Do we keep the genostomy tube for post-operative 2 weeks? What advice do you to give the patient on genostomy tube as we continue oral feeding with genostomy? Well, after you starting your oral feeding, you can remove the genostomy tube. But sometimes, if you are having a suspicion of leak or any stricture formation, then you can ask the patient to keep the genostomy tube and not to do anything to that and let it be like that just without feeding or doing anything there, keeping it as a tube. That's all. We continue oral feeding with generous feeding. No need to do oral feeding and generous feeding together. If you had started the patient feeding orally, generous feeding can be stopped, but generous can be kept there. The tube can be kept. This IOL is the only possible curative surgery option if macules and oringas are non-curative. Yes. Macules and oringas are considered non-curative. Ivalois is also not a really a curative surgery, but in the Western world, the UK and the United States countries, because they don't believe the Japanese technique, they believe that the Ivalois is the curative surgical option. But Ivalois, the usual survival rate is about 30 to 40%. Akiyama survival rate is about 60 to 70%, 5 year survival. So actually, Akiyama is better than the Ivalois, but Ivalois is the considered curative option because they remove the mediastinal lymph nodes in the esophagus and the lymph nodes around the stomach in the abdomen, but they don't touch any lymph nodes there in the neck. In Akiyamas, they remove the lymph nodes of the neck also. The rationale for that is esophagus is a structure starting from the neck and going into the abdomen. And there is a periesophageal lymphatic network. As soon as the tumor breaches the muscularis mucosa and coming into submucosa, there is a submucosal lymphatic network, and the submucosal lymphatic network directly communicates with the periesophageal lymphatic network, which is starting from neck to stomach, the whole length of the esophagus. So any tumor which is coming into this periesophageal lymphatic network can spread from neck to abdomen. So that is the rationale of doing a neck, thoracic, and abdominal lymph node dissection in esophageal carcinoma. That is what Akiyama has shown in long time ago, 1986, 87 time. They have shown in lymphocytic studies. This is how the lymphatic spread happened there in the esophagus. So that's how they have rationalized their three-field lymph node dissection. Whom should be participated on the MDT? So minimum there should be your surgeon and the oncologist and the pathologist and the radiologist. And if you have a palliative specialist, the palliative specialist also should be there. And if the patient is having any other cardiac problems, renal problems, things like that, so that specialist also should be around if depending on your patient. But in an oncological MDT, there should be the oncologist, pathologist, surgeon, and the radiologist. Chromosome syndrome, is it pre-malignant? Yes. Is there necessary to do a barium enema as well? No, no need to do barium enema at all or barium swallow at all if you can do a specific upper GI endoscopy. For squamous cell carcinoma, the distal mets can we give radiotherapy as palliative treatment? Well, in esophageal carcinoma, if they have developed distal metastasis, that means there are microscopic metastases everywhere. So giving a radiotherapy to one or two metastasis does not mean anything. Because when you are finished the radiotherapy to one metastasis, there will be another three will come out. So they have to give that also. By the time you finish those three, another 10 will come out. So there's no end to that. So there's no plan of giving radiotherapy to the metastasis. And you can't give, usually you can't give radiotherapy to structures like liver or lung because those structures are very radiosensitive. So when you're planning large area of normal tissue being irradiated, so they will get radiation induced hepatitis and radiation induced lung fibrosis if you are going to do radiotherapy to those structures. So generally not done. Can can cervical or thoracic esophageal carcinoma give rise to loss of appetite? Yes, it can. Usually after spreading it into the liver, squamous cell carcinoma. Endocarcinoma can be there very rarely because esophagus structure there can be submucosal mucus glands are there. There are only two structures in the whole gastrointestinal tract where there are submucosal mucus glands. One is esophagus, other one is duodenum. Those are for the Brunner's gland and duodenum. There is no special name in the esophageal glands. These glands rarely can develop adenocarcinomas in the esophagus. So they can also have loss of appetite. Even upper esophagus, you can develop adenocarcinomas. For the Barrett's, do we do surgery if it is high grade or just radio frequency ablation? Well, high grade Barrett's, there is an indication to do a surgery. Because high grade Barrett's and pre-malignant conditions are very closely associated. So you can do a surgery for high grade Barrett's. Palliation, can we use a PEG as option? Yes, PEG can be used as option. Yes. Any more questions? 51. Are there new ones that come? Oh, that's all right.
I think you had to answer a lot of questions.
Lot of questions were there, and I'm very happy because that means they have been reading, they have been studying, so that's very good. I'm very happy that they have been reading. Very enthusiastic group.
Yeah. Uh, Any that we have to conclude it because I think you took a lot of time. You will be very tired.
Actually, I'm very happy to give this opportunity to me, and I'm very happy to teach and to discuss this topic with them.
Excuse me on behalf of Wayaba Medical Faculty students, thank you for dedicating important time for us, sir, and hope you do more sessions for us. Really, thank you, sir. So thank for the our department and Dr. Nixon, sir, for organizing this. Thank you so much, sir. Thank you for the opportunity.
Okay, thank you very much. We have to give, I would like to thank Dr. Ranga Pereira. He's a leading oncology surgeon in Sri Lanka. Also, he's doing marvelous job in KDU. Therefore, he will be one of your examiner in future. Then we have to say good night to him. Other thing is that tomorrow that we have another session. It is done by Dr. Nalinda Munasinghe, Department Head, Surgical, University Surgical Unit, Faculty of Medicine, Ragama. Therefore, you hope that we can meet tomorrow session. Thank you very much, Dr. Ranga Pereira.
Thank you,
Good night.
thank you, sir. And
Dr. Ranga, and I understand that you are on call today with your busy schedule, and thank you very much for helping our student. And in the meantime, I would like to convey my gratitude to Dr. Dixon and our demonstrator, Dr. Kalhara, for arranging all this setup. Thank you very much.
thank you, sir.